So I'm going to talk about health disparities rooted in the pregnancy exposome. I sort of set out looking at the pregnancy environmental exposures and then exposome, thinking that it would, let's start there because it's a well-described, discrete life interval. So maybe, and that's where lots of things are rooted, so maybe we will be able to start to describe that a little bit easier. But like we've learned today, nothing's easy about the exposome, and you really have to be thoughtful even when you're zoning in on a certain thing. So here's Christopher Wilde. So David mentioned this. His concept was all environmental exposures from conception to grave. Can't do it all, but let's do what we can. And I am a pulmonologist, so I was thinking more about respiratory disease, and particularly childhood asthma, which we know is rooted in fetal life. And there, like anything else we want to talk about, there are clear health disparities along socioeconomic and racial ethnic lines. And multiple exposures. We're appreciating the complexity of the multitude of exposures that really drive that programming of respiratory disease starting in utero. And this is the typical life course framework that we all think about. Well, let's describe what's going on here in pregnancy while the fetus is developing. And what we're forgetting is this mother herself has had a life course, and that we might need to understand the context that she brings in to that pregnancy to really get closer to public health, precision public health, through what environmental factors might be operating there. And just like we're talking about for any individual, the mother is embedded in this socio-ecological complex system as she goes through life. And this slide, I'm not going to go through this, but you've seen this in many different ways across the day here today. It just shows the complexity that we have to understand. So what we really need to do, if we're looking at the health effects on this baby, is really to understand where that mother has been. Are there critical windows for the mother? What are the key environmental influences that might be really shaping the physiologic milieu that this child is going to be exposed to during development? And how does this shape her own response and reactivity to the environmental influences that are going to be ongoing during that pregnancy? And here's a quote that I think of that's hanging in my office from Maya Angelou. You can't really know where you are going until you know where you have been. And if we're really going to get to precision prevention and precision public health, we really have to put people into this context. We've heard it a couple of times here today, whether it's your ethnic context, what country you live in, your environmental influences, and the biological embedding of those is going to be quite different. So I'm going to talk to you about what we've learned, or what we think we're learning, because we're still learning, about prenatal programming in the context of ongoing longitudinal birth cohort studies that we've been doing in the Boston metropolitan area and here in New York City now. And then in the PACER laboratory, our physiologic assessment of children's environmental risk, looking and going deeper into the biological embedding of those environmental influences as they relate. In this, we're going to talk again, focus on respiratory. Well, why do we see disparities? Because you start to understand that racial ethnic groups have different opportunities on where they live, opportunities for education, economic standing, etc. It's not by chance or by choice that you're exposed to many of the things that we have. And that sometimes it's the social influences, it's the policies that are made by institutions. We've heard about structural racism. We're gonna touch on that a little bit today. And I'm going to go to, we measure a lot of environmental influences. We measure air pollutants, we do indoor allergens, we measure a whole spectrum of physical and chemical exposures, but it's the social exposures that raise to the top. And it really dovetails with what Dr. Ortiz was talking to us about earlier today about toxic stress, that it's really the social exposures in different contexts to interpersonal traumas, et cetera, that seems to be driving a lot of what's biologically embedded that might be explaining some of the disparities that we're seeing in asthma in our group. And this is a cartoon by Gary Larson. All the forest animals remember where they were when Bambi's mother was shot. Trauma gets biologically embedded because it is so outside the norm of what we should be experiencing as human beings. And one way we measure this, and it gets to what Dr. Idris was saying around some of the ways they're looking at biological embedding that might relate to low birth weight in preterm infants in some of the work they're doing, we look at hair cortisol, different from the salivary cortisol, and we were talking about how to measure it. And then our women, our pregnant women, when they deliver, at the time of delivery, we take a piece of hair from the nape of the neck, right at the root, and hair grows about 1 centimeter a month. And so you can go back in time from delivery of that baby to however long their hair is and look at the accumulation of cortisol production across that pregnancy. And we do it by trimester, so we usually do 3 centimeter chunks to look at trimesters of exposure. And we quantify cortisol in those hair samples. And we looked at it here in relationship to race, ethnicity in our population. White, non-Hispanic, Hispanic, non-Black, and Black, non-Hispanic. And it really is different across those racial ethnic groups, and it's really African Americans in our population that had the highest level of cortisol in the hair as they come into that pregnancy and over the course of that pregnancy. And when we looked at what might be explaining it, we had done an array of measures of different psychological measures, life event measures, racism, discrimination experiences, financial strain, et cetera. It really was the interpersonal trauma, and it was the remote trauma, not what was happening right now during this pregnancy, but we had asked them during their lifetime, had they experienced interpersonal trauma, emotional abuse, physical abuse, sexual abuse. And we looked at it by race, ethnicity, and you can see that our African Americans in our cohort that we're following had the highest frequency of exposure to that sort of interpersonal trauma, and that is what was driving the high levels of cortisol in the hair of the women that we were following. Now we've gone on to link it to, in this case, higher level cortisol. Now we're looking at salivary cortisol. We did a salivary cortisol rhythm. We asked them to give us 5 samples a day over 3 typical weekdays, and we averaged that to get these rhythms. And like Dr. Ortiz was saying, the mothers who had that flattened diurnal rhythm in their salivary cortisol mid-pregnancy were much more likely to go on to have babies that were at risk for asthma, low levels of lung function as we followed them out, and we can link it to other things like neurodevelopment and behavioral problems as well. We're not the only ones. Many people are doing this now. But the question is, where does that come from? And it's really the mothers who have high levels of interpersonal trauma, particularly traumatic stressors, but it can be accumulation of traumatic and non-traumatic stress, disrupted HPA axis, and higher risk in those infants. And you really start to see disproportionate burden on our African American populations in our case. We also have linked interpersonal trauma, cumulative exposure across the life course to disrupted immune function in kids at birth from these mothers. In this case, we're looking at highest levels of total IgE, which is an early risk factor as that kid then goes on and gets bombarded by the other things in their environment to develop things like asthma. We've looked at other dosimeters. How does it get biologically embedded? And one that we're looking at is mutational load in the mitochondrial DNA, called heteroplasmy. And Dr. Kelly Brunst, who was a postdoc in my lab, now junior faculty at the University of Cincinnati, who's pursuing this work, took a look in our population and said, well, what's driving differences across race, ethnicity in that mutational load, this marker of cumulative oxidative stress, which can come from lots of different environmental factors, as we know. But here we looked at a measure of lifetime cumulative traumatic and non-traumatic stressors, the LSCR, Lifetime Stressor Checklist. It's a survey tool where you can measure over the woman's life course how much exposure to stress she's had. And again, we really saw, again, it's our African American women, highest mutational load, highest dose, dose of cumulative oxidative stress. And that you go on and you can link then to a number of health problems in the kids, including wheeze, asthma, and lower lung function. Another dosimeter that we take a look at is telomere length. Telomere length is another marker that is a dosimeter of cumulative oxidative stress. It parallels what we see with the mitochondrial heteroplasmy. And the interesting thing about your set point at time of birth, if you're born with a lower, shorter telomeres, you're going to lose it faster over time, and it's a marker of elevated risk for lots of different things. And it's environmentally induced. One of the things that predicts low cortisol or shortened telomere length at the time of birth is that elevated cortisol. And it's particularly boys that seem to be impacted by that when we looked at it by sex. Another way we measure lifetime accumulation of potential environmental exposures is just SES. So in the mother, over your life course, your socioeconomic status as a young child, 0 to 10, during adolescence, during adulthood prior to this pregnancy, and during the pregnancy. And one of the ways that's been a valid way to do that retrospectively, because I don't remember what my parents made, but if there's home ownership at different stages. And home ownership, just that simple question of did your parents own their home in these different intervals, turns out to be very predictive of lots of different things. And so we looked at it, and we looked at whether, see if I can do it without turning this off. We looked at whether it was mom's critical windows when she's exposed. So is it that early life period of SES that really predicts differences in that cortisol level, or these other dosimeters that we're looking at? Is it accumulation over the life course? Or is it a pathway variable? Your lower socioeconomic status in childhood puts you on a trajectory that's going to keep you at risk for these different exposures that are disparate across socioeconomic status. And it really seemed to be that pathway model, but that early life childhood SES was predictive, and it was, in this case, it was independent of race, ethnicity, and pregnancy health and other things that we were looking at. Another reason why we really got to think about the mom in the context of her own health related to the environmental exposures that she might be experiencing around the time of conception and carrying a fetus, and how that might relate to risk for the child. In asthma, we know that if you have a history of asthma, the mother has a history of asthma, there's an elevated risk in that child for also going on to develop allergy or asthma. But if mom's asthma is particularly active during pregnancy, meaning she's having lots of symptoms, it's not being controlled by the medications that you're giving her, and that might be intrinsic severity of the disease, but it might also be environmental factors that just are driving her asthma to be active during that time period. They're at particular risk. And one thing that we showed is when we looked at interpersonal trauma predicting risk of asthma in the child and what might be the pathway mediating it, it was maternal health. So mom's long-term exposure to interpersonal trauma, cumulative over her life course, did predict asthma, elevated asthma risk in the kids, but it was mediated not through being more likely to smoke, having lower socioeconomic status, living in a community with more exposure to allergens in the home like cockroach, those kinds of things, as well as air pollutants. It wasn't any of that. It was actually her asthma being out of control. So that disruption that gets biologically embedded is contributing to that, and that is really the pathway that's operating. And we really got to start thinking about that when we're caring for these women and trying to optimize health, not only their health, but for the next generation. And it was different in boys and girls, and in this case it was boys that were more affected by that again. Now what about, I mentioned that it's not by choice or chance often where we live and how we are disproportionately potentially exposed to a number of different environmental influences that might affect mother's health at the time that she's carrying the baby. This is a map from the 1930s of the Pittsburgh area, and it's redlining. It's the homeowners loan corporation who made decision to categorize different practices for how they're going to hand out loans. And they separated by A, B, C, and D, and that's what the color coding is as far as how those policies were going to be laid out. And this went on from the 1930s to the 1970s. It determined where you could get a home loan, where you end up living. And it disproportionately impacted minoritized populations. And in Pittsburgh, it was particularly the African American populations that ended up in lower resource communities that had higher level of exposures to environmental toxins, whether that was safety in the community, increased air pollution, etc. And that's a group of colleagues there at the University of Pittsburgh, Sally Wenzel, and some of the graduate students there took a look at these categories. They geocoded all the severe asthma patients that they had in their registry, and they took a look at the distribution of who had more severe asthma, greater asthma morbidity related to where they lived based on the ABCD levels on this map. And they found, one, the highest morbidity and most severe asthma was in the D category, which were the lowest resource categories. And it disproportionately affected African American people. Then they looked at distribution of environmental factors that might be explaining that. And you can see on this map that you were more likely to be exposed to multiple ambient air pollutants, for example. And that was probably one of the drivers of what they were seeing for asthma. Alexander Schuyler is an MSTP student there who worked with Dr. Wenzel, who was willing to share these data. This is a paper that's just coming out in the American Journal of Respiratory and Critical Care Medicine. And this is where they looked at the different health outcomes, level of lung function, et cetera, and they really saw a graded association between the highest resource A categories down to the lowest resource D categories. We have to start looking at upstream factors to really understand, well, there are things we can do now, but what do we really need to change so these sorts of patterns don't continue and we don't continue to see those persistent disparities. Now, one of the things that we wanted to look at, talking about air pollution, you can see that where you live is going to determine that you might be more burdened by things like air pollution, multiple air pollutants in those lower resource populations. Most of us who do air pollution work and link that to things like respiratory outcomes and lung disease, we've really looked at one pollutant at a time, maybe a couple in the same model to see which one seemed to have the greatest effect. New methods are coming along where we can actually look at mixtures of air pollution, not only just the on average over the course of pregnancy, but take into account that more highly resolved temporal association that others have been talking about to be able to look at critical windows of effects. So we worked with our colleagues, Brent Kuhl at Harvard University, Andrew Wilson at the University of Colorado, who helped us model to look at a mixture of 7 air pollutants in our cohort to look at, this is just in the Boston metropolitan area where we had all those 7 pollutants that we could throw into the model. And we looked at it in prenatal over the pregnancy period, predicting lung function when these kids were 6 to 7 years of age. This just shows you that you can actually take into account the correlation between these different pollutants, still seeing this time varying effect with this new methodology, which was recently published. And then we actually also took the windows of vulnerability averaged over those windows of vulnerability and did linear regressions to take a look at what pollutants might, it's a little bit easier to understand what pollutants might be driving the effects on lung function. And what we found was ozone, ammonium, and organic carbon were the three that kind of bubbled to the top. They had the greatest effect on lung function in the kids, but ozone seemed to be more of an obstructive, affecting obstructive patterns, primarily in girls, as did organic carbon, which looked to be hitting the small airways. And then the ammonium seemed to have an effect more on overall growth and total lung capacity. But that was more in boys. So you start to see the complexity that we have to tease apart there. But what this tells me is as clinicians, we should be mapping these people and understanding where they are and understanding their potential exposure to these sorts of things, particularly if you have an asthmatic patient who's pregnant and you want to help optimize those kids. These are the kinds of clinical questions that we're going to have to respond to as we understand these environmental influences on health. Now, Bob showed a map of, I think it was lead violations across the New York boroughs, and here's our population mapped, and we're looking at lead and other metal exposure levels in our women, both in New York City and Boston, enrolled in this cohort. These are pregnant women. We took urine samples from them, and we looked at the distribution of the various metals that are shown here. The brown dotted line is relative to NHANES levels, just to show you where our population is falling. And then we looked at the differences, whites compared to Hispanic non-blacks in our black Hispanic populations. And you can see that minoritized women just receiving routine prenatal care here at Mount Sinai Hospital, much more likely to be exposed to multiple potentially toxic metals. But we don't screen for metals during pregnancy. We also looked at individual level factors. Of course, it's the usual players, the social determinants of health, lower education, lower income, et cetera. And we looked at neighborhood level factors. And if you lived in a neighborhood that had a high crime index, for example, you were much more likely to be exposed to those multiple metals as well. Now, women who have higher levels of exposure to a number of these toxic metals, we looked at this by doing a mixtures analysis using weighted quantile sum index, and we showed that you had the kids born to those women who had higher levels of this mixture of toxic metals had lower telomeres at birth as well. We have to put these things all together ultimately and really change our scope of how we look, the lens that we're looking through as we look at the risk for not only that woman, how do we optimize her health during that pregnancy, but also be thinking about that developing infant, and not just for birth outcomes. These things get embedded and they have long-term implications for chronic health disease like chronic lung disease. And I'm going to put a plug in for please let's think of that context as we hear the next series of talks that are going to look at data science approaches. How do we not look at one biomarker at a time like we're talking about here? And we have started looking at omics platforms and trying to integrate these as well to characterize these same women and children. And as Dr. Stigoni gets up here, talks about data science, et cetera, let's all start to think together, how can we keep this context in our head as we try to do those types of analysis, design those types of studies, and interpret those findings and translate those to our patients and our communities as we go forward. And I think that's the challenge that I face every day. We don't have all the answers, but I think we know the questions we need to ask. We need to be thoughtful, come together, and really push on putting exposomics in clinical translational science and how clinicians are going to use that as we go forward. We have to start talking the same language. And thank you very much.